All right, the day is almost done, but if everybody could just stand up, stretch your legs, because this is going to be a lab talk. Yep, stretch. Yeah, I like that. Arms up. So, good. Stay up if you can. How many of you guys know that, you all know that March is Myeloma Action Month, right? I didn't hear much about that, but so Binding Site is the company that I work for, and we're also supporting it. And we're taking an old theme, Mambo for Myeloma, and we're not taking it so literally. So we're donating money to IMF for every video that is taken. So if you want to, after this or at some point, you can take a video of yourself just dancing and having fun. $50 for each video goes to the IMF to help raise a cure. And just to show you, I love the people that I work with in San Diego. Our head office is in San Diego. And I'll show you a quick clip. Oops, wrong one. This wheel is fast. So where's the mouse here? I can't see it. Gotcha, thank you. Actually, I'll just use the laptop. There we go. So this is some folks at Binding Site in San Diego. We don't worry about it being myeloma per se. And you can see this guy, where is he? This guy just showed up on the day. He didn't rehearse at all with anybody else. And if you look, you'll see he's a little bit off, but you can't tell when you're in a group. So go ahead and get a video together. All right. I got another one I can show it to you later if you want, but anyway. So last talk. So if you want to upload a video, yeah, you guys can sit if you want, or you can stay standing for the whole talk. That's fine too. If you want to help support the IMF and raise money for a cure, if you upload it, you can take a video, put it on Twitter yourself if you know how to do that. If you don't, you can go to this website and just drag that file over. And these instructions are on our website. So if you go to www.thebindingsite.com, you'll find it all there as well. So it's #BindingSiteMambo. And with that, I'll tell you a little bit about Freelite and Hevylite. So Binding Site is the company that I work for. We manufacture these tests to help doctors monitor and diagnose myeloma. And so I'm going to talk today about what is myeloma. I don't think I even need to do that after listening to Beth's talk. The only thing is I heard soft serve ice cream is being served at our break. So, anyway, myeloma is one of a number of diseases called monoclonal gammopathies. And if you break that word down, it's really mono meaning single, clone meaning one cell. And it's a gammopathy because they're producing, the cells themselves are making too much of this one protein. And there's 3 different names we scientists give to it, which is not always the smartest thing, and it makes it confusing for you, but I want to try to help clarify. And that is that these single cells are making too much of what's called a gamma globulin. That's the older name for it. More recently, it's been called immunoglobulin, and it's also called antibody. Whenever I use any of those words, immunoglobulin and antibody means the same thing, okay? So a monoclonal gammopathy is simply one cell producing too much of an immunoglobulin. So of all the monoclonal gammopathies that we're seeing in the Mayo Clinic over the last 50 years or so, you can see MGUS, which is monoclonal gammopathy of undetermined significance. That's that disease where you just have an M spike, but there's no Crab symptoms. So there's no problems with any organs. No hypercalcemia, no renal dysfunction, no anemia, bone, you're all good. You've just got too much protein, one type of protein. And those people are not treated. That's 57% of all of them. I'm going to focus mainly on myeloma today, the 18%. But the other diseases that you'll see here, smoldering multiple myeloma and amyloidosis, are both very related diseases. So when I started at Binding Site, I came out of a scientific career, and I was actually And I'd worked on myeloma before, but I didn't know why it was called multiple myeloma when it's a monoclonal gammopathy. So I was confused, like mono and multiple in the same disease. So I had to do a bit of research, which I like to find out, get to the bottom of things. And so the name comes from many, and myel comes from the Greek term mulos, for marrow, so bone marrow, and oma is the suffix for tumor. So really it comes from, it means many marrow tumors, is what it means. And the history of it, the first described case was in 1844 in London, England. A woman named Sarah Newberry had 4 years of back pain and bone pain, and she fractured her bones. And eventually, when she passed away, when they did an autopsy, they found that portions of her sternum were replaced with this red pulpy substance. So it was all mushy and soft. And that was the myeloma eating away at the bones. And so that's where the name came from in the first place. Some 30 years later, Dr. von Ruzitsky, a Russian physician, also saw 8 bone marrow tumors in a patient. And in Russia, sometimes it's still called, it's named after him. And Dr. Otto Kohler, a few years later, also saw these marrow tumors. And so the name really comes from those first descriptions of the disease. So what is it? We know a lot more about it now, and you're all very well educated on it as well. So I'm going to take you through a little bit about it and a little bit about the normal immune system before I talk about myeloma and what it is, and then the Freelite chain testing. So you know that in your blood you have red blood cells that carry oxygen that are shown in red, and then these purple cells are really the white blood cells, and they're important for fighting off infection. And these are circulating throughout our bodies, and they circulate through our lymphoid organs, places like the spleen and the thymus and the lymph node. And here's a few other of those white blood cells, T cells and macrophages, that help fight off infection. So white blood cells help fight off infection. And one of the important ones in the case of myeloma are these B cells, which then become, when they get activated, they become plasma cells. And those plasma cells, then their job is to make antibodies. They're antibody production factories, because that's going to help fight off infections. And so that's shown here. You can see the little antibodies. I should work on both sides. So they make antibodies, and that's really their function. So in the normal immune response, in all of us, in healthy individuals, whenever we're infected, what the job of the B cells and they have on their cell surface, on the outside of the B cell, is a little bit of antibody, a piece of an antibody, and it's recognizing one piece of something. And we have millions and millions of these B cells in our body, but each one has only one specific receptor that's going to bind to one piece of some bacteria or virus. So they circulate and normally just don't do anything. They just circulate around and stay quiet because they haven't found a virus or infection that antibody on the surface binds to. But when they do have a right fit, I've lost a pointer and I'm going to stop trying to point. So when they do have a right fit, finally, they get all activated. And what do they do when they get activated? They make many copies of themselves, and they get activated and turn into plasma cells. Why? Because remember that antibody that was on the cell surface of the B cell? Now the plasma cell is not going to keep it on the cell surface. It's going to just start releasing it out of it. So it can those antibodies can float throughout our body, find any more of those viruses or bacteria, and help neutralize them and kill them. So really, during infection, you get this huge amplification, lots of copies of that plasma cell, so you get lots of antibodies produced to clear the infection. After the infection is done, though, we don't need all those plasma cells. They're just going to clutter our body up, so a lot of them need to die. And they do. So our immune system is constantly going through these waves of production and then death of some of the cells, but we keep around a few so that the next time you get that same infection, you'll have produced antibodies, you'll neutralize the virus before you even have any symptoms. So that's part of the memory of the immune response. The case in myeloma, though, is there's too many plasma cells. And there's too many of one type of plasma cell. And that's why it's called a monoclonal gammopathy. One type of plasma cell making one type of antibody. So monoclonal gammopathy. So plasma cells in our normal healthy immune system are making these antibodies. So this is what they look like. If you see there the Y-shaped structure there, it's got two black parts to it. Those are called heavy chains. And the two green over there are called the light chains. And so you have those four coming together. When they fit together, that makes one intact antibody or intact immunoglobulin, one whole piece. So four of these pieces come together to make a whole antibody. And the plasma cell shown in purple there is releasing either an antibody with a kappa light chain, or another plasma cell there is shown secreting one with a lambda light chain. So you can secrete either kappa or lambda if you're an individual plasma cell. But remember, we've got millions of these in our bodies, so we're always producing some of each, kappa and lambda. And in addition to having the intact antibody being produced, plasma cells are funny. They make extra amounts of light chains. And we don't really understand why. We think it's to make that whole process of putting these four pieces together efficient. So if you make lots of extra pieces, then they'll make it efficient. But the kappa light chains that are not bound to the heavy chains, they're on their own, and the lambda light chains that are pink there, that are not bound to the heavy chains, those are called free light chains. So what it means to be a free light chain is really not bound to an antibody, not bound to a heavy chain. And that's what we're measuring when we're measuring your free kappa, free lambda. Did somebody have a question? No? Okay. So that's what we're measuring in our test. So as I said, our immune system doesn't just have one type of plasma cell and one type of antibody. It's a little more complicated. So what I'm showing on this slide here is you've got the purple cell at the bottom, which is a plasma cell. And then on the leftmost one is an IgG kappa. So the way that we describe them is by what kind of heavy chain is it and what kind of light chain is paired with it. So black here I've got, in this cartoon, the black are the G heavy chains. So that's why that's an IgG. And this is a reminder that those three things mean the same thing. Antibody means the same thing as immunoglobulin, and immunoglobulin is abbreviated as Ig. So whenever you hear Ig something, that's immunoglobulin. Is it going to be IgG or IgA or IgM? And the way we talk about which immunoglobulin it is, I'm going to come over here now. So the way we talk about which immunoglobulin it is by the heavy chain. So here's the black, those are Gs, and you can see green in all my slides, the green is going to be kappa, and the pink is going to be lambda, okay? So now if I show you another plasma cell that we have in our body, it's a lavender heavy chain. That's an IgA kappa. And now I'm going to have you guys guess as to what this one is. Somebody yell it out so we don't have to be here all day. Yes, excellent. We're going to do the next one, which is, I'll tell you the first one. It's IgM is the red chain, is the red heavy chain. So what's that one called? What's the whole antibody called? IgM kappa. Good. It wasn't just, so you guys yelled out kappa, which is true, but IgM kappa. And this one is? Okay, so you guys are pros at immunology. Excellent. So those we have in our bodies, we have all these different types, and we have two more, IgD and IgE, but those are much less common in myeloma. But those are the different types of plasma cells that we have in our body that are secreting, each one secreting one type of antibody. So in the case of myeloma then, we kind of classify them, we classify the patients based on what your myeloma cells are releasing. So the blue circles here are the myeloma cells. And you can see the Y-shaped structure that's got the heavy and light chains. That's the intact antibody there. And they're also releasing pink light chains as well. So they're releasing some free kappa. And about 80% of patients are actually intact Ig myeloma. So they are IgA or IgG or IgM. But they're also secreting free light chains as well. Some of you have myeloma cells that are only releasing kappa light chains or lambda light chains. So only the free light chains and not any intact antibody. And that's shown here, an example of kappa light chains. And then lastly, there's an unfortunate few that are not releasing very much, and those are non-secretory or oligosecretory. And so their myeloma cells are only secreting a little bit of light chains, if anything at all. And the reason I say it's unfortunate is that the levels of these proteins that are being released, the antibodies that are being released, that is a simple blood test, which is giving doctors an idea of how much myeloma is in the bone marrow. So instead of doing a bone marrow biopsy, this is kind of an approximate measure. Is your myeloma getting worse or is it getting better? And for non-secretory, they don't have that ability to be able to monitor with that simple blood test. So I went over what is myeloma. And there's a bunch of terms that you'll hear, and you're probably very familiar with already. It's a hematological malignancy, just meaning it's of the blood cells. It's a plasma cell dyscrasia, so it's the plasma cells that have the problem. I talked about monoclonal gammopathy, one type of protein being released. I talked about the intact or free light chains of the proteins that are being released. We talked about the bone marrow, as Beth did as well, very well. Because all this is happening, myeloma cells like to live in the bone marrow, and they end up eating away at the bone, and because of that, that's where you get your pain and your fractures from, because it softens up the bones. And then finally, our normal immune response, all our normal B cells and plasma cells are also in our bone marrow. So if it's getting crowded out by all the myeloma cells, then your normal ones don't have a chance to do their job, and you have a hard time fighting off infection. Okay, so the next thing I want to talk about is the symptoms and diagnosis. And this is something that all of you know way better than I. Hopefully you're not feeling like this, even though it's the end of the day. But patients that present with fatigue, 32% of myeloma patients present with fatigue to their physicians, 73% with anemia, 58% with back pain. So these are really hard to diagnose because it can be caused by so many things, right? It can be a vitamin B deficiency. It can be you're not getting enough sleep. It can be just the fact that we live busy lives. So it's a real challenge to diagnose, and it's a real challenge for primary care doctors because that's where the patients go first. And that's one of the initiatives that we're doing right now is really trying to raise awareness to primary care physicians to think about myeloma as with these vague symptoms. So in terms of diagnosis, the old criteria are shown here, and that is for a diagnosis of myeloma, you've all heard about the CRAB criteria, right? You need that end organ damage, the greater than 10% plasma cells in your bone marrow. And it used to be that you have to measure this monoclonal protein either in the serum or in the urine. So that's changed recently. And the new diagnostic criteria are the bone marrow has to have more than 10% plasma cell, so crowding of the bone marrow with plasma cells. The CRAB criteria are still there. Now, and this Beth mentioned as well, but she really just called us a ratio. And so I'm going to talk to you today about the ratio and what that means in your lab results. So the criteria are the CRAB criteria and these new biomarkers. So these are for patients that may not have, you don't have to have one of these CRAB criteria. If you have more than 60% plasma cells in your bone marrow, then you're considered myeloma and you should be offered treatment. If your light chain ratio, kappa over lambda or lambda over kappa, depending on which type of patient you are, if it's over 100, then you're probably going to get real myeloma within 2 years, so you should be treated. And similarly with more than one focal lesion by an MRI. So these are what are called the myeloma defining events. That says that it's definitely myeloma. So in terms of detecting the monoclonal protein, so this has been going on for a very long time, and if you look back at our history of how myeloma was first discovered, when we think about the detection of it, we have to look back to 1848, and Sir Henry Bence-Jones first found a protein in the urine of patients with mollites osseum, which just means softened bones. And this scientist decided to heat people's pee up. And so I don't know why he would do that, but he heated it up, and then he cooled it back down a little bit, and it became cloudy. And he says, aha, that doesn't happen in normal pee. And that's how he discovered Bence-Jones protein in the urine. So it actually just makes the solution, it makes your pee cloudy when it's heated. So what's going on in myeloma? I mean, you all know that if this is, say, your bone marrow with all these different plasma cells releasing their different type of antibody, then myeloma is the growth and replication of too much of one type of plasma cell. And for example, in this case, it's Iga Kappa that I've shown here. And remember that when we classify the different types of myeloma patients, when we're trying to detect them, you can see that the intact immunoglobulin is only in 80% of patients. So we really want to be able to detect with more than one technique. And if we can detect the light chains, we can really detect all three classes of myeloma patients. and help track them. So how is it diagnosed? How do we actually do this? It's so funny, actually. Now some of these people are looking over here, and so as I move, I have such power. So it's a blood draw, as you know. We take it to the lab, and this cartoon is just to say that it's not as simple as this arrow in the head. Myeloma is a real challenge to diagnose. So I'm going to describe to you what happens in the lab with your tube of blood. So the blood's taken to the lab, and then this is a person in the lab, and he's got a little tiny, he or she's got a little bit of it in this pipette, and they're putting it in a slab of Jell-O. This technique is from the 1800s. So it's an agarose gel. So they put it in this slab, basically a slab of Jell-O, with a little hole in it to allow you to drop a little bit of blood in there. And then we separate all the proteins in your blood based on their charge and their size. So if you imagine all these little circles, green, red, and yellow, being different proteins, so they have different, each protein has a slightly different charge on it. And if we apply an electric current across it, going from negative to positive, then the proteins that are negative will be attracted to the anode, to the positive here, and they'll move based on their charge. So these proteins, these red ones, came down to the positive end of the apparatus, which means they're most negative. So they got attracted to the positive. And likewise, these are the most positive. So it's a way of crudely separating out all the proteins in your blood. And then, because we can't actually see proteins, we have to stain them with a dye. And in this case, this example I'm showing you, it's a red dye. And the most abundant protein in your blood here is this red. So this red is albumin. And you can see it's quite a fat band. And so we call each of these bands. And then it's quite fat. And then we describe these ones. This is alpha 1, alpha 2, beta, and gamma. Guess what? We didn't know what was in those bands. We didn't know what proteins were in there back in the 1800s. So that's why they're named like this, alpha to gamma. Remember that term, the three things that meant the same thing? Gamma globulin, immunoglobulin, antibody. That's where the gamma globulin comes from. That's the gamma region of the gel from back in the day. So, and what's done is then there's a tracing that depicts how dense this color is, and then you calculate the area under this curve to give you a quantification. So this is a typical healthy individual. You can see the different types of proteins that we know that are in each of those bands. They're just really a clump of proteins that are in the same position. And this is the gamma globulin. This is where all our antibodies are, all those things that are helping us fight off infection. And so that's why it's called gamma globulin. So, healthy individual, here's the albumin. Here's the albumin, and here's the gamma globulin region. What's the difference here with this one? It's an M spike, right? So that's why it's called an M spike, because when the lab folks look at it, they see the albumin, that's always a reference point, and they say, wow, that's a really dark black band, and when you do the densitometry or the scanning, you get an M spike. I'm making those guys at the back work, when I go back and forth. That's great. So, so this is the serum protein electrophoresis technique that I'm talking about. Sometimes you hear it called SPEP, SPE. Serum protein electrophoresis is really just that, taking your serum, taking the proteins in there, and electrophoresing them. So you're separating them based on electric current. And that's how we get the M spike. So these techniques are the protein electrophoresis that can be done on your serum or on your urine to see if there's a monoclonal protein, right? The gamma globulins that were there before were all fuzzy and just gray in the healthy individual because each one is slightly different, so they don't go to the same position in the gel. But in the case of the monoclonal protein, it's the same protein. It goes to one place, and there's a lot of it, a lot more of it. And that's why you've got the M spike. These techniques have been around since the 1800s. And that's great. They've served us well, and we still use them today. But since 2001, we've got this the Freelite test that's been helping in diagnosing and monitoring patients with myeloma. And so I'll talk a little bit about that now. And as I mentioned, again, the serum protein electrophoresis does a pretty good job of detecting the intact antibody, but it doesn't detect the light chains very well. So the Freelite chain test helps complement that testing. And when you have the two together, if those two are ordered together, you're really able to detect 100% of patients, and you're able to monitor them as well. So what is it actually measuring? It's actually just measuring these guys that I told you were not bound to the heavy chains, the free kappa light chains and the free lambda light chains, not bound to the intact immunoglobulin. And the test is really, we have a test that's detecting this little piece of the light chain that's normally bound up to the heavy chain. So in the intact antibody, it can't be seen. It's only when the light chain falls away from it or is separated from the heavy chain that it can be detected. And that's what we're quantitating. So we have one for kappa, there's one for lambda, and then you get a ratio which tells you if there's a clone or not. So one thing to be careful of is your results should come back in milligrams per deciliter or milligrams per liter, because light chains in the healthy population are really small. We have a very small amount of them. We have lots of these intact immunoglobulins in our body. That's on the order of grams, so that's 1,000 times more. If your results are coming back in grams per liter, it's the wrong test. And that test, the total light chain test, doesn't tell you anything about your disease, because the difference is free light chains in our body, we have this much, we have very little amount. So if you have a clone that starts producing a little extra, and it doubles the amount, like from 5 to 10, from 10 to 30, or so if it triples it, then you believe that that's a real difference, and you'll know that there's a disease there. But in the case of total light chains, if you've got, so I was talking about 10 to 30 milligrams per liter there. If you've got 2,000 milligrams per liter of the total light chain, and you add 30 more, 2,000 to 2,030, do you think that's a big difference? It's a very small difference. And within the variability in the assay on a day-to-day basis, or and biology of your disease changing a little bit every day, that is not a believable difference. So that because the light chains are so low in healthy individuals, you can really detect small changes that happen in myeloma. All right, so as I mentioned, Freelite can be used in diagnosis. It can be used to monitor your response to treatment. It's one of the first results that changes when you get treated. And that's because the free light chains have a very short half-life in your body, so that when you start killing off the tumor cells that are producing the light chains go away. Whereas with the intact IgG, it hangs around for about 3 weeks in your body, so you might not see the change as fast. You can use it to help adjust therapy if your treatment's not working, and when you're in remission, when you're being checked every now and then, it can help detect a small blip really early, so you can get a quick treatment before it gets too far. So the Freelite test that I've been talking about, you're going to see as free kappa, free lambda, and ratio on your lab results. Remember, we've all got small amounts. These are the normal ranges. So anything outside of these ranges is something to be a little bit concerned about. And then the ratio of kappa to lambda is 0.26 to 1.65 for the healthy population. So that's kappa over lambda ratio. So if your ratio is very high, then you're certainly a kappa secretor. That means your myeloma clone is secreting kappa light chains. If your ratio is in the decimals, over here, then you've got a lambda secretor. Okay, so that's just a way of knowing. So don't worry so much about the exact which direction it is, because that's just telling you kappa or lambda, because it's a ratio. So we talked about detecting the monoclonal protein in terms of the free light chains, and now I'll talk to you a little bit about Hevylite, which is a newer test, and it's really coming back to this idea of if this is a clone that's growing out and it's an IgA kappa, that heavy and light chain pair, those are paired together, right, to make one intact immunoglobulin, is what's called the involved. It's called involved because it's the one coming from the tumor cells, from the myeloma cells. And we call the immunoglobulin has the same heavy chain, so the same A heavy chain, but the other light chain, the lambda light chain, that's called the uninvolved. And you can take a ratio of that, just like with the free light chains, and it tells you whether you've got a clone or not. And so we have tests for IgA, IgG, and IgM. And these are useful, again, for monitoring patients with myeloma. So by doing that, though, what's interesting is that if a patient is IgG kappa, what we've started to learn from this test, which we didn't know before at all, is that the amount of IgG lambda will sometimes get suppressed. We talked about this before, right? The bone marrow is overcrowded, so your normal antibodies are suppressed. So the amount of this suppression, the uninvolved heavy light chain pair, that's what we call it, just the uninvolved, the more that's suppressed, the worse off the patients are, because it's an indication of not only how much of the cancer is there. So the IgG kappa in this case of a patient, that's the involved. That tells you how much tumor burden you have. But the IgG lambda can tell you a little bit about your normal immune system. Is it functioning well, or is it suppressed? So those are the kinds of extra information that we're getting out of Hevylite now, and it's still early days. So you can distinguish between IgG kappa and IgG lambda. So you distinguish between these pairs, and you're more specifically measuring the one that's coming from the myeloma cells instead of total IgG. All right, and there are different tests. Hevylite's measuring the intact antibody. Free light chains are measuring the unbound light chains that are not part of the antibody. Okay, so now that you guys are all pros at what an M spike looks like, right? I've highlighted it in black so you know. And you can see that this patient's being treated pretty well. And you can see the black spike is going down and it disappears. And down here, I know you can't read the numbers, but if you look at the red are abnormal numbers for Hevylite. And what you can see here is that patient's in remission, and then they start to see a little bit coming back on the M spike, right? Well, Hevylite stayed abnormal a little longer, and it became abnormal 5.5 months sooner than you could see it on an SPE, on a serum protein electrophoresis. So the idea is if you're in relapse, Hevylite will be able to detect that little bit of disease coming back so you can get treatment sooner. And these are, again, very early days for this test. So how would it be used? With all the tests, and I know you guys have a lot of tests that you have to try and interpret, but in terms of after you get your therapy and you hit a complete response, for example, you can get a stringent CR as the speaker was saying earlier today, if the free light chain ratio is normalized. And Hevylite can help you detect that residual amounts of little bits of disease. Well, why would you want to do that? And the idea is that that's simply a blood draw is doing that kind of thing with free light and Hevylite. So if it's abnormal, then you can continue to monitor with free light or Hevylite. So keep watching those numbers until they normalize. Once they're normal, then you start to look at minimal residual disease. But there's no point in going down to a bone marrow biopsy and doing all these really sensitive techniques. Why would you put yourself through multiple bone marrow biopsies unless you're a real glutton for punishment? But so the idea is that maybe Hevylite will be useful here. Is that once you're in CR, by the electrophoresis, no M spike detectable, can't see it by immunofixation, get a Hevylite done. And if it's abnormal still, then don't do a bone marrow, because there's certainly still disease left. Keep monitoring with Hevylite. Once that normalizes, then if the doctor wants to do a bone marrow, then that's the time to do the really, 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 really sensitive technique that can detect a very tiny amount of disease. Okay, so did you get that picture? You want it? There you go. I mean, I'll send you the slides as well if you guys like. Anybody wants to email me, feel free to email me. So, all right. So a few more things I want to go through are interpreting your free light results. So they're a bit challenging sometimes. I've got some sample cases here. A patient walks in with fatigue, and here's the serum free light chain results. So kappa is 15, and the normal range is between 3 and 19. Lambda is 24 milligrams per liter, and the normal range is 5 to 26. And kappa lambda ratio is 0.7 in this person, and there's the normal ratio, 0.26 to 1.65. So now this is where I get to ask you questions, and you have to yell it out. So what would you say for the kappa? Is it low, normal, or high? Good. Lambda? Perfect. And normal. So this person, and there's no other tests were detecting any monoclonal protein. So this fatigue might have been a very common cause of fatigue of something else that's not myeloma. So I'll give you another example. What would you guys call this? Kappa is high, right? So this patient came in with back pain and fatigue. Kappa is high. Lambda is good, normal. And the ratio is high. And there was also a monoclonal protein detected on protein electrophoresis. So really, that's what you're always looking for, inside or outside the abnormal range. And then, why don't you guys yell out what this one is? Yeah. Lambda is high and low. Good. So in this case, it looks like it's a monoclonal lambda free light chains. So one thing that, so this is an example of if you graph out your data of your results, you can see that this person, here's the myeloma cells and secreting the light chains, and they're up in the thousands here when they got treated. This is an old slide, so they got treated with thalidomide, and you can see it dropped for a little while, then it stabilized, got treated again. So you can monitor your disease with this. Now remember, the amount of light chains is telling you about how many myeloma cells you are. It's really just a simpler way, instead of going into your bone marrow and trying to figure out how many myeloma cells are there, free light chains give us an idea of how many there are there with a simple blood draw. Okay? This is an example of how fast they can, upon treatment, the blue here are the kappa free light chains. Look how fast they drop compared to the monoclonal Ig monitored by SPE. So this happened in the first few cycles, or first few time points, and this other one, it really took like 200 days to see it with the intact Ig. That's that fast response I was talking about. Light chains can show you really quickly whether your treatment's working. Yeah?
When they monitor both the IgG and the M spike is going to be more sensitive to changes?
No, this M spike is measuring the monoclonal IgG. It's less sensitive. It will probably move a little slower. They're both important in some people. Sorry, the question was, is the monoclonal Ig more, or the M spike, right? The M spike is that more sensitive to monitor your treatment than the light chains? They're both important values to keep an eye on, because in some people, the monoclonal Ig might go down and then it'll stay down, and in a later relapse, only light chains will come up, for example, or vice versa. So because myeloma is always changing, it's important to watch them both. But light chains, because of their half-life, are usually faster to move. Okay. So in terms of Hevyite, we talked about Freelite. We talked about interpreting the results. In terms of Hevyite, it can be used to monitor response to treatment, and it's important in looking for remission, but it can detect really small amounts of disease that's left. It's not as sensitive as flow cytometry. It's not as sensitive as the gene sequencing and PCR, but it avoids a bone marrow biopsy for you. So it can be used before a bone marrow biopsy. I see somebody shaking their head saying thank you. Yeah?
What is the sensitivity? You know, MRD is usually quoted about 1 in a million cells.
Yeah.
And as far as I know, SPEP and IFE, I think maybe 1 in 100, something like that.
Yeah.
Is Hevylite somewhere?
So from patient to patient, you can't tell. So right, so the question was, what is the sensitivity of Hevylite compared to some of these flow cytometry, which is 1 in a million? It can detect 1 in a million cells. If there's one cancer cell among a million normal cells, they can detect it, which is absolutely true in the bone marrow when you're measuring cells. These are measuring the proteins that are being released by cells. Now, your cells may be producing 10 light chains, and this woman over here might be producing 100 light chains. So if you double yours to 20, then you've seen a doubling. But for her, she'd have to see it to go 200. So it's all it's different from patient to patient, because you're looking at protein production rather than actually the number of cells. So it's hard to say. It's certainly not even close to 1 in a million cells, though. So, okay. One important question that always comes up from patients is, why do sometimes patients, when I give patient support groups, they show me their results, and they say, why do my results keep going up and down like this? And they graphed it out, and it looked great. This is an engineer in Pittsburgh, I think. Graphed it out in Excel and was going like this, and I'm like, whoa, that looks terrible. I don't know what's going on. And then I looked at the scale, and the scale was really, really tiny. So it was going between 0.1 and 10 or something. So the important thing is, think about 20 to 30%. If your numbers go from 100 to 130, and then they go to 120, it's not changing. That's just normal variation of even stable myeloma patients can see changes of 20 to 30%. Don't get stressed out about 20 to 30%. If you start to see 50% changes, then that's when you want to start looking into it more. And if you see a second result that confirms the first one. So the other thing, so you want to look for 2 results. If you do see larger changes, like 50% or more, you could start asking, was the test sent to a different lab? Or did the lab get a different instrument? So, and your doctor is not going to know this stuff. They don't know those details. So then you have to find out from your doctor's office, where does the lab get sent to? Does it go to, where does the test get sent to? Quest or LabCorp or your most local cancer centers will run it as well. And you got to do a little bit of sleuthing or digging. You can also email us at Binding Site. We are happy to help you interpret your results in any way we can. We know which labs are running the test because we're the only manufacturer of it. So if we're always happy to do that if there's a problem. But if that's the case, if there's some change in the laboratory instruments, then you want to take a new sample, run it at the old lab or the new lab, run them both. So now you have to reset your baseline. So if you were running at 1,300 and then your lab spiked up to 2,000, then if you find out, well, it turns out that they've now sent it to a new lab. Now take a new sample and run it at both places and now reset yourself. Okay, so now you're really at 2,000, but your disease hasn't changed. It's just because there's a change in the lab. Yeah?
I believe you said earlier that if your test results are grams per liter, it's the wrong test.
Correct.
Why? If you take the grams per deciliter multiplied by 10, you'll get the number anyway.
You're absolutely right. So the question was, if I said earlier that if you're getting results in grams per liter, then it's the wrong test. And he says to me, well, if it's in grams per deciliter, you just multiply by 100 and you'll get the right number. And you're absolutely right, but that's just not the way it's reported. So all labs will either report in milligrams per liter or milligrams per deciliter.
If you're using 2 different oncologists
Mm-hmm.
at 2 different facilities, your general oncologist and your specialist, they could be running separately. One could be using
Correct.
that. And I'm having that. And what we do is multiply it by 10 when we compare the notes.
Right, but they're always in milligrams. They're not in grams per liter.
In milligrams.
Yes, so, but I said grams per liter before. So if it's in gram components. Yeah, so the test can be run and you can get them back in milligrams per deciliter or milligrams per liter.
Then we multiply.
Then you multiply to get it, that's fine.
And then we compare it.
Right, but what I said is if it's in grams, grams are 1,000 times more than milligrams. And so, yeah. Okay. The last thing, I know we're running a little bit late. Are you guys still okay? Does anybody want to get up and stretch? The last part I wanted to talk to you about was why did you get a urine test? Why do doctors get asked for a urine test? And I just wanted to give you the basic biology behind that. And that is, so you know that these immunoglobulins and the light chains are circulating through our blood, and they all get filtered through the kidney. And that's shown here. And so what I'm going to show you is really what happens in the kidney with your light chains and your immunoglobulins. And so this is my artistic rendition of a kidney. This is one nephron of which there are millions in each kidney, each of our kidneys. Red here is the blood flow, so blood's going to be filtered here. Here's the green kappa light chain. Pink are the lambda light chain. They're usually dimers, so they're twice as big. And over here is the measurement of how big they are. 25 kilodaltons is a kappa light chain. Kilodaltons, think of it as pounds. It's just really a measurement of size of a protein, so in that small units. Lambda, remember they're dimers. There's 2 of them stuck together usually, so they're 50. And then an intact immunoglobulin is 150. So in all normal situations, what happens is our blood is flowing through this glomerulus, and it's got a 40 to 60 kilodalton cutoff. It's got a filter. Think of it like cheesecloth, okay? So the blood's going through this cheesecloth, and anything that's less than 40 to 60 kilodaltons can flow right through. Anything that's bigger stays up. So normally, the kappa and lambda light chains don't really go through that very efficiently. Or sorry, kappa goes through it very well because it's less than that. And what happens when it hits the proximal tubule, we reabsorb those proteins and break them down and recycle them. We reuse them. And we can reabsorb 10 to 30 grams of total protein per day. And what the net result is, nothing goes through into our urine. So in a healthy individual, our kidneys are working well. We're filtering this stuff. We're reabsorbing the proteins and recycling and reusing those pieces, and nothing gets into the urine. So now what if there's damage? So if there's too much of a monoclonal protein, let's say there's too much kappa light chains, it could overwhelm this reabsorption capacity. And then you end up seeing kappa light chains into our urine. So there was no problem here of the glomerulus, no problem with the filter, that's fine. But we're just overproducing too much kappa light chains because of the myeloma, right? So it's overwhelmed this capacity to reabsorb and recycle. Can't handle it, so the rest of it just flows through. So you get kappa light chains in your urine. Now what happens when you've got a damaged pore, that cut off, now that cheesecloth is not cheesecloth anymore, it's got a tennis ball could go through there. So now you've got your intact antibody, your kappa light chains, your lambda light chains all flowing through there. It's certainly overwhelming all our ability to reabsorb and recycle. So you end up seeing all of them come through into the urine. And so that's what they're testing for. So the idea in testing the urine is looking for damage to the kidneys and overproduction of the light chains, or of the monoclonal protein. So we talked about a lot of things, a lot of scientific concepts in the lab results. We talked about monoclonal gammopathies, the different and the identical terms, gamma globulin, immunoglobulin, and antibody. I talked about myeloma being too many of one type of plasma cell. The antibody structures, remember there's two heavy chains, two light chains that come together, and they're detected with serum protein electrophoresis. And in terms of other testing, we can detect them with the free light chain test, and it tells you how much myeloma is present. And then the new Hevyite test can tell you about smaller amounts of disease, maybe before a bone marrow biopsy. And lastly, if you ever want more information about this kind of thing, you can feel free to call the binding site, email me, email the binding site. Also on our website, under the Understand tab in monoclonal gammopathies here, we have resources like webinars and things like that you can view and learn also more. Don't forget about Mambo for myeloma. It doesn't have to be Mambo. I can't Mambo, but I'm in some of those videos. We also are sponsoring the iStop multiple myeloma trial. We are the ones that are doing the free light chain testing for that Iceland study. And this is the farm in Vermont where we have sheep. And the sheep are there, they are our raw production. So we start by immunizing sheep with human light chains, and we take a little bit of their blood, and that's what's used in our test kits. My email is there, naveen.bangia at the binding site, if you have any questions or if you want a copy of the slides or anything. And with that, I'll take any questions.
All right, let us get a mic to you guys. Thank you, Naveen. That's a tough one. Right over here. We're just going to do a couple. Hang in there for a second.
I just wondered if this
Try it. It's on
Okay.
now.
I just wondered if this test is used for detecting other diseases or cancers, and should this test be used in a screening for normal patients?
So it's not used for other diseases. It can go up with other diseases. So autoimmune diseases, the light chain, I'm presuming you're talking about light chains, the free light chain test. Light chains go up in patients with autoimmunity, but both kappa and lambda go up. So then the ratio usually stays about the same. And that's why the ratio is really helpful for determining monoclonality. And should it be used in screening? Right now there's no indication to use it in general screening, unless the patient has symptoms. I mean, that's different than general screening, but if patients have symptoms like bone pain, fatigue, back pain, then if there's suspicion for myeloma, it can be run together with SPE.
Alana?
PSA over here.
So, thank you for your talk. When you are done, I want to make sure that you go out and take pictures for the I Donate campaign. There is, every time you take a picture, something is posted on the website. And Kelly maybe was going to talk about that.
I will. Thank you, though. Sir, last question here.
Thank you, right here.
Thanks. If you have not had a Freelite test prior to treatment, and then subsequent to treatment you have a Freelite test, do you then not have a baseline? How effective is that test?
It's still effective. It doesn't tell you how much you've dropped from at the beginning, but all subsequent measurements are still monitoring you, right? So wherever you're at today, it can tell you whether it's continuing to go down or if it's going to come up. So it's still I think it's still valuable, for sure. Even though you don't know where you were when you started with your initial myeloma, but you can still track it forward.
One more, please, and
One
that's
more?
it on this
Okay.
top. You're up right there, miss.
All right.
Yes.
My question,
You're on.
Yeah, you're on.
okay, are you the only one that's doing this? And I'm asking.
Me personally, I'm
No,
in
no,
the
I
lab,
mean your
like-
company. I mean
The
the company. And I'm asking because we talked about the consistency. If somebody else is doing the same thing, would there be the same consistency?
So we are the only manufacturers of the test.
That
And we sell it to Quest and LabCorp and all the reference labs, as well as to all the cancer centers. But having said that, they have each might have a different piece of machine to run it on. And for each of those different machines, we make a slightly different test. So it's adapted for each machine, but they should be consistent across the board, still within like 10% of each other. So, yeah.
Okay, Naveen, are you going to be with us tonight?
Yep, I'll be
All
around.
right, he'll be around.
Later today and tomorrow.
Round of applause. Naveen, thank you.